think while we're treating glaucoma patients, I think the dilemma now is about should we prescribe preservative-free medication for all, and what is the choice of preservative, and what are the choices available to us, and so on. Have the slides on, please. How many of you believe that preservative-free medication is for all? For all patients across.
They're buying from my pharmacy.
Yeah, and they're all generic. So. True, there is a case for it. That's what I'm going to talk about. I think I've given my slides. It's on the laptop there.
So while he comes on with the slide, what will dictate your choice of medicine? Efficacy, or whether it is with a preservative or without a preservative? Efficacy. Murali, I think you need a lot of convincing for them.
Yeah. The talk is a little different.
Yes.
Yeah. So patient-centered glaucoma management and the case for preservative-free. So when we manage a glaucoma patient, we have to, of course, decide first the target intraocular pressure. We need to educate the patient regarding the disease itself, what is the nature of the disease, the need for follow-up and management and so on, and the application of eye drops. Most of us would probably demonstrate for the first time the application of an eye drop and probably teach them the punctal occlusion so that we don't get the side effects or the systemic side effects. Evaluate for systemic disease like you were talking about, asthma and health problems which can probably interact with the drug intolerance. Keep that in mind always that a patient is being prescribed a medication which he probably needs to use for the long term. And of course, we also have to keep in mind the talk which I'm going to focus on today is about the ocular surface, which is relatively common in glaucoma patients. So the adherence and support aspects for the patient that we really need to monitor whether the patients are following what has been told to them regarding the number of bottles, the number of times they have to use, and they come back for the regular follow-up and so on. Encourage lifestyle modifications which would assist them in better health and better management of their disease. Counseling of the patient and the family regarding the disease, the need for drops and the follow-up. And the most important thing is about the family screening. Once you diagnose somebody with glaucoma, don't miss the opportunity to screen the relatives, screen the siblings in particular. Don't miss the opportunity to screen for glaucoma. This is probably the best screening tool for glaucoma. Don't go into the population screening for doing glaucoma camps. It doesn't work. This is the best way to screen for glaucoma. A common reason for discontinuing glaucoma therapy is usually the ocular surface OSD, ocular surface disease development. In the general population, it's said to be somewhere between 5 to 30%. But in the glaucoma population, the people with glaucoma, the elderly with the need for drops and so on, it's much, much higher. So more the number of medication, more the number of bottles, more the number of drops per day, and the chronic duration of therapy, obviously we're going to increase the problem of ocular surface. And majority of the ocular surface, the local side effects in glaucoma therapy seems to result from the preservatives than the actual active compound itself. But there's some belief that the actual compound itself may be important in side effects, but the preservatives seem to be causing more of the local side effects, such as ocular surface inflammation, the conjunctival inflammation, allergic reactions, and of course the dry eye. We have various preservatives which are available in glaucoma medication. BAC is the one that is about 70% of our glaucoma medication has BAC, ranges from 0.003% to 0.02%, various strengths, various drugs, various companies, and it's basically a detergent. A detergent dissolves the cell membranes. We have polycard, we have SOC, we have perborate, and we have borate, sorbitol. All of them cause oxidative. Basically, what these preservatives do is they try to destroy the microbial organisms that may contaminate the bottle. And that's the reason why you're putting in a preservative. It's like you have a preservative in your pickle, preservative in your jam. Those kind of preservatives are put into your eye drop bottle to preserve the drop and not to actually protect the patient. So, but that's a side effect of what we need to keep in mind. The cytotoxic effect of the BAC, which is the most common benzalkonium chloride, which is the most common preservative used, is decreased corneal, conjunctival, trabecular meshwork, and ciliary epithelial survival. And we all know about the conjunctiva, the cornea, and the goblet cells and so on. What we don't know, is, at least many of us don't know, or till recently I didn't know, that the trabecular meshwork is also affected by the BAC. So BAC can actually influence the way the outflow actually changes and is influence the control of intraocular pressure as well. Besides all of these cytotoxic effects of BAC on ocular tissues. Does BAC worsen the glaucoma? Yes, it probably does. And the back exposed human trabecular meshwork as compared to trabecular meshwork open and glaucoma patients, you see the studies which have been performed, the changes induced by back on the trabecular meshwork has been clearly demonstrated. So what does back do? I think in terms of symptoms, pain, discomfort, tearing, people are quite symptomatic with ocular surface staining, increased breakup time, the low Schirmer scores, the punctate keratitis, the worse OSD, so people who do the OSD evaluation, and of course the subconjunctival inflammation trial. All of us who treat glaucoma patients who have been on medication for long periods of time, you all know the eyelids can't be spread apart, the orbits tend to sink, and they have this periorbitopathy related to the prostaglandins. We have all kinds of problems, and you will find these are the candidates who don't really do well with trabeculectomy also, even though if you use antimetabolite and so on. So the clinical consequences of the back toxicity is that the OSD is going to be there. It's going to get worse. You've already had a pre-existing mild dry eye and so on. And also you will find the glaucoma gets worse for various reasons. One, the patient is not going to be adherent, is intolerant to drops, does not like the drops, does not tolerate the drops well. You will find the compliance adherence issues will come. The IOP control goes away, and they don't use the drops which are uncomfortable. You'll find if you give 2 bottles or 3 bottles, the most comfortable bottle will be used by the patient, and sometimes it is a lubricant. So which is why I take care not to prescribe a lubricant to all glaucoma patients as a routine, because what is most comfortable, they will use. What's uncomfortable, they will not use. So unless it's really important, don't co-prescribe a lubricant to all patients. And the long-term use of preserved medications increases the risk of surgical failure. I think we all know that this is from various publications that people who have been on chronic therapy, especially back-containing medication, the success of trabeculectomy drops. You will not get the same result with the trabeculectomy as compared to somebody you are operating. Just maybe you diagnosed last week and you're operating this week, you will find the primary glaucoma is the results are much better with trabeculectomy, and somebody who's been using back-containing medication for a long number of years. So the benefits of PF glaucoma therapy are there, definitely there. Prevents ocular surface inflammation, eliminates the side effects of the preservatives, reduces the, increases the adherence and persistence with therapy, probably maybe a little more cost effective due to the better adherence and so on. And the patient comfort is the most important thing. When you give a drop or a medication, the patient should be comfortable with that, and therefore the quality of life improves, and overall the outcome of glaucoma management improves. So many studies have compared the benefits of switching to a preservative-free glaucoma medication. The conjunctival signs and symptoms obviously get better if you use a preservative-free drop. I'm not going to go into all of the details of these publications, but it suffices for us to know that a PF medication definitely changes the scenario of signs and symptoms. Patients are a lot more comfortable. And switching actually causes a reduction in the ocular symptoms. Suppose somebody had intolerance to PF-containing medication, preservative-containing medication, you switch them to a PF, then you find that they definitely feel better. Definitely the T-bud times and their ocular surface evaluations, the scores improve with the preservative-free medication. But there's no difference. There's a little worry about the back actually helping the drug penetrate the eye. And that's why we feel that sometimes, for example, bimidaprast, one company brought out to the bimidaprast strength, which is actually higher back than the previous backs. So what happened was the theory was that it helps penetrate the drug penetration is assisted with the back and so on. But many trials have shown that between the PF and the non-PF containing medication, the IOP reduction is not really significant. So you can probably give a PF medication. You look at the glaucoma guidelines from various societies and publications have suggested the use of preservative-free. You avoid preservatives in people who don't tolerate these kind of drops with the preservative. And on long-term treatment with glaucoma medication, I think it's probably better, like you all suggest in the beginning. Given a choice, you would probably, it's like saying, would you like organic food or not? All of you would like the best available food if possible, given the choice, but availability, cost, and other issues prevent us from giving it in all our patients. Various technologies are available in India as well. About the one type of technology, the bottle which is available is called the Aptar bottle, which is actually made by companies like Cipla and so on. We also have the Novalia type of bottle. There's a slight difference in the bottle technology between the two. The Aptar bottle actually allows there's a sealing membrane, there's a dual channel for the drop to come in, and there's a little bit of air that gets in back into the bottle. There's a membrane which doesn't allow the air to get contaminated and go back into the bottle. That's what the Aptar is all about. Whereas the Novalia actually has some For microbial integrity, there's some kind of a silver in the plastic material which is lined within the bottle. So that's the basic difference between the Novalia and the Aptar. Patients sometimes have a little difficulty in squeezing the bottle with both the Aptar and the Novalia because it doesn't have the nozzle appearance. It has a little bump in the bottle, as you can see. So there's a little difficulty. Patients sometimes express difficulty in getting drops out of this bottle. The drop actually appears very small. So most of us would be aware that the drop size of what we would want in a glaucoma medication should be between, let us say, 20, at the most 30, but most of the commonly available drops which we now get in our commercial glaucoma medication will give you something between 30 and 50 microliters and more. So conjunctival cul-de-sac obviously cannot hold such a large drop. So having a smaller drop actually makes a lot of sense. This is the Aptar bottle, and this is the mechanism of how the bottle actually gets the drop out. Bottle squeezing opens the tip seal, dispenses the drop, the tip seal closes and prevents the backflow. And the incoming air which goes back into the bottle actually gets filtered. So this is a very nice technology. It's very nice on at least the engineering part of it. For those of you who want to know more about the Aptar technology, the Aptar Pharma has a website which you can look up and see how the Aptar. I'm not going to show you the video of how the bottle is going to show you maybe a very brief clip of how the bottle works. I mean how the bottle sort of. There's a company which makes this bottle, and you see the drop that comes out from the two channels. And as it comes out and delivers the drop, sometimes these drop technologies take ages to understand. It's a very small drop that comes out. I think it's about 15 to 20 microns. So PF therapy will definitely benefit all, but obviously we can't give this expensive, relatively more expensive, totally preservative-free glaucoma medication for all. So a targeted assessment would actually help identify those who need it the most. So you need to look at the patient history, their symptoms, the other ocular disorders, what other medication they are probably using, ask about the dry eye symptoms, the occupation, the systemic disease, systemic therapies which can actually have an effect on the possible dry eye development and so on, especially older age, the female gender, and all these history about the systemic disease. Then a quick visual assessment about the ocular surface, about the periocular skin, the debris at the canthi, the hyperemia. All of this should be evaluated, including the tear meniscus, tear film, maybe even a T-butt and a Schirmer if possible. And how much more to add to a glaucoma mammogram? We start doing visual fields, you do gonioscopy, you do intraocular pressure, and you look at the optic disc, you take a picture, do an OCT, and finally say I want to look at the dryness as well. And then one more test and one more evaluation. So I think we need to balance the need for which test for which patient, especially the ocular surface. The symptoms, history, and a quick evaluation should actually suffice. If you really want to go further, you can actually go evaluate further and have a cornea colleague look at the ocular surface. So patients who would actually benefit the most from preservative-free glaucoma therapy are those with concomitant dry eye, patients receiving multiple bottles, very elderly patients, especially whom you know that the ocular surface is compromised, very young patients in whom you want to probably give medication for a longer duration of their lifetime, patients with serious medical risk factors, known systemic illness like rheumatoid arthritis and diseases which are known to cause dry eye. You're going to plan for a glaucoma surgery in which you want to stop the medication containing back, and perimenopausal women and contact lens users. So to summarize, preservative-free glaucoma therapy is probably a new standard in glaucoma care, been there for a long time, but we now have almost all companies that have come out with the preservative-free medication. Glaucoma is a lifelong journey. Holistic management extends beyond IOP control, especially caring for the ocular surface health. Many Indian pharma companies have launched the PF medication, and it should probably become an integral part of our glaucoma management. Thank you all for listening.
So, Dr. Murali, just one question. When you see a patient, you have diagnosed the glaucoma, and now you want to start treatment, your choice would be medication with preservative or without preservative when you're starting off on a naive patient?
I generally start with the PF medication, and I give the choice to the patient. Suppose the patient for some reason can't afford the more expensive PF medication, I also give the alternative of not using a preservative PF medication.
So a large part of this will depend on the kind of practice you are.
Absolutely.
So if let me ask Dr. Jyotsna, she heads a secondary center where most patients come from a rural background. Would preservative-free medicine be your first choice?
No, sir. They can't afford preservative-free because there are more expensive medicines.
Economics plays a very important role for across all patients. That's why I said you need to choose your patients.
So before all this actually came, in India, preservative-free medicine, the first one was, they were timolol-based eye drops. And they were truly without any preservative. they didn't do well. The company withdrew them because the shelf life was reduced. And doctors were not used to this concept there. And remember, an average Indian patient will put up with the redness and the itching and the irritation for a cheaper drug. And it's only a small select few that who would probably need, though more and more people are becoming conscious, but cost still plays a role in the long-term management of disease. Tony, you want to add something?
Just one quick thing, that the one drug that we want preservative-free is timolol, and nobody will be able to do it because of price control.
Because of?
Price
Price control. Yeah, so preservative-free was very expensive. They came in unims manufactured by a company, I don't remember the name, but cost and I think the shelf life were issues.
If you run your own pharmacy, I think most of us will be prescribing lubricants by tons. So most of us, lubricants are very expensive, and most of them now are preservative-free. Very expensive lubricants. Most of them are anywhere between, say, 300 to 700 and so on. So pretty expensive medication, lubricants. With that in mind, I then explain to glaucoma patients that a preservative-free medication is far better in terms of the lubricant, plain lubricant, which you're probably using it without preservative anyway.
So compliance gets better because number of instillation times also gets reduced, and spacing and dilution of the glaucoma medication.
I think compliance adherence is the key element in glaucoma management, and we have seen that with various combinations as well. And even we are very skeptical about the triple combination that recently came in, whether it would really work at all, so many drugs into one bottle and so on. We did find that the drug actually works quite well, because the compliance immediately improves. With three medication, one bottle, your compliance is actually much better than 3 bottles or 2 bottles.
Preeti, you want to say something? Let's have it at the last thing, because
One thing, we have to press on the patient. I do agree that I love the triple combination, but when they miss one drop, they're missing all of it. So
All or
it
none.
has to be sort of drilled into them, don't miss.
so there's a 48-hour gap which happens in the window period. So I think on this note we will end. Thank you very much to the speakers and to all of you for being here.